Well, and I want to go back to the spring for a minute because I remember talking to primary care doctors at that time, and of course, during the widespread lockdowns, many of them had to shut down non-emergency care. Can you tell us a little bit about what that was like for you? And I know a lot of doctors also took a really big financial hit in over those couple of months. So, what was your experience like?
It was a challenging time for us on many fronts. Obviously, financially, one, uh, that means doctors were losing their jobs, they were losing their ability to pay their rents. But I think the thing that struck us most is we lost the ability to see our patients in person. And that's what makes family medicine and primary care truly a special field. The ability to give someone a handshake, the ability to sit in a room with a patient and feel what they're going through, help them get through those struggles. And when you lose that connection, that doctor patient relationship, it makes for a very difficult scenario of how to help that individual. In the beginning, in March time, there was a lot of stress for us in the primary healthcare space because patients were coming in with what looked like to be traditional viral symptoms, but we weren't able yet at that moment to identify, was this COVID-19 or something else? So we were there placing our lives on the line, our staff, our patients, and we were trying to figure out the best way to help our patients. And we had to pivot incredibly quickly in order to maintain the integrity of our practices. So what ended up happening? There was a major shift in the March, April timeframe to telemedicine. We were trying to upgrade our offices, trying to upgrade our clinical workflows so that we were able to continue delivering care in a meaningful way, despite the fact that we weren't able to see our patients sitting in front of us in our offices. What happened as a result? Well, primary care visits dropped. In fact, there was an article recently in the Journal of American Medical Association that said despite the huge surge in telemedicine visits, we had a drop of 21% in overall visits, a drop of 50% of blood pressure measurements, and a drop of 30 to 40% of cholesterol checks. So while we're doing our best as family medicine providers to care for our patients, telemedicine cannot replace the one-on-one individual visit with their primary care doctor.
Well, and I wanted to ask you about that telemedicine. As you said, it's really increased, but what are the drawbacks to it? And, especially for patients with complex needs, where does telemedicine not sufficient for treating them?
I think telemedicine has a lot of room for growth, not only from the utility of it, the fact that doctors can make use of it, but also in its technological capabilities. I would love to see more companies put investments in creating devices that patients can have in their homes, whereby we can listen to their hearts. We can improve the physical exam that we can do virtually. Because right now, that's the biggest shortcoming of it. When a patient comes into my office and I need to evaluate them for chest pain or abdominal pain or ear pain, I can do a proper physical exam. But through telemedicine, that's not feasible. So that's its number one shortfall. The second one is nothing will ever suffice or compete with a one on one individual visit with a patient in the room. You're able to read their body cues, nonverbal communication. You're able to hug them if you see them struggling. And I think that human connection is lost through telemedicine. That doesn't mean telemedicine is bad or it's not going to be useful. I think there's a lot of utility for it, especially for complex care where patients might not need to travel 2, 3 hours to get a consultation with a physician. So while I think it has absolute true drawbacks, I do think there's a huge future for telemedicine within family medicine.